Hey, everybody, John Sfiocla here for our monthly Growth Innovator series. I'm happy to be here presenting to you from our beautiful offices, actually in the flesh, no longer just in my house. So COVID is at least in abeyance for a while. So it's great to have you here. I'm delighted to welcome an old and dear friend, Bill Fandrich, who I will introduce in just a minute. And we're going to talk about how health informatics and AI are really revolutionizing patient care and what we really think of as the future of care and how that is evolving. So, Bill, welcome.
Well, thank you, John, and great.
Let me first give you a little bit of background on Bill. So Bill and I have known each other for a long time, actually back when he was at Blue Cross Blue Shield of Massachusetts. And his bio reads in a very humble way around providing critical IT operations and strategic technology leadership. But Bill is not just a technology executive. He is a truly senior executive in healthcare. And he's the kind of person who both understands what are the dynamics of the different players in the industry, as well as where the technology and the care models are going and what makes sense to do. And in his portfolio throughout his career, both in Massachusetts and now at Detroit, in Michigan, he is really a person who leads what new things are happening in the industry, is willing to make those investments, and also has relationships at the industry level and with his clients in a way that drives that forward. We've all met executives who are role players or functional players or industry players. Bill really spans all of those and is truly a broad senior executive. And he's also got a great sense of humor, and he drives race cars on the weekends. So I'm looking for any excuse to get up to his racetrack and bar his Corvette from his really fancy garage on a race car. Bill, welcome. It's great to have you here.
Great. Thank you, John, and thank you for the kind words.
In terms of agenda, we're going to get to some of what's really going on in terms of the drivers of healthcare informatics, what data is getting collected, what's going on. Then how is artificial intelligence really layering on top of that, if you will, in terms of capabilities and new activities? And then what's really going to happen to patient care? And we talk about here in terms of redefining patient care through interoperability. That's a technical way of saying care anywhere, anyway, as needed, and what are going to be the models. And then really technology's role in this shift to value-based care. And so we're going to go through that in our normal format. We're going to have a pretty open conversation. But what Bill wanted to start off with, basically, how do you think about what are the new kinds of information and how's it shaping up? There's a huge push for EMRs, and there's all this telemetry data now and so forth. Yeah. How do you think about it? What do you think's flash and smoke, and what's real?
Well, I think it's such an interesting question, and I will briefly take a step back so there's a context and then directly answer the question. From what being in the industry as long as I did, and coming, quite frankly, early in my career through college with such a deep technical background, physics, pre-engineering, computer science, with the belief that really was what we needed to do for businesses to be successful, I quickly learned and, quite frankly, pivoted my thinking and built my career on this premise of really it's about how value can get created and why does this matter and how can it matter and what else has to happen to successfully take advantage of. I go back to the days when I was in the consulting business when it drove me crazy, even though I wasn't even part of it. But as some people remember the days of SAP when they first were expanding and everyone was buying them, it drove me nuts saying, why does this company buy that or license that solution and have these unbelievable transformational results? Other company buys the very same technology and they literally go out of business. And the reason I say that, it's the same mantra with data and information. I've been through generations where the whole focus of data was things like data warehouses. Our success is based on us being able to, there have been very good success stories in what people did in bringing data together in models, and then there's probably 10x more failures on that where nothing ever happened. And part of it is the weight of what you try to, everybody's looking for the panacea. And there is zero question. The fundamental, and I say this strategically for our company, I don't have to own everything or hardly anything anymore directly, but what is
Hmm.
core? What is the foundation that we will build everything on is how we is on our data, our analytics, and our integration. And
Right.
although those are simple words, and I'm not going to go into all the details of what that means, that to me, and it has to be at an enterprise. If it's in someone's unique department, it's not leverageable.
Right.
But we have to be responsive to that. But one of the things that the proliferation of this is it's not just if the battle was won, if the
Mhm.
world was going to be successful based on how much data you had, we would have payers would have won this a long time ago. It's how you apply it and use it. So when we think about data now, what the emphasis is, and I just got off a conversation when I was rushing on to get to this on this same very topic. It's saying I can get you EMR data. I can get you this clinical data. Can we please talk about it? If you have it, what are you going to do with it? How are you going
Mhm.
to apply it? How does it change the experience? And at the highest level, people can talk about, but when you really get down to it, they
Right.
don't understand the workflow. They don't understand the process. And to me, there is the from a volume of data, the things that will matter, if you think about a human being, a person,
Mhm.
and we call it a member, and you think about them in
Yes.
their health,
Mhm.
and not health in the traditional setting of when they're sick, what doctor do I get them to? What's the best hospital? What's the
Right.
best care treatment? Thinking about the things that matter in their lives that impact their health, the
Right.
social environments, the economics, housing, jobs, support systems, mental health. You have to have an ecosystem of data that
Mhm.
allows you to bring this stuff together very dynamically so that you can answer those questions in
Yes.
a relevant manner when it matters. Not
Yes.
just, I can do it retrospectively and say, if all this happened, good things would
Sure.
have happened. You need to be able to do it. And some people call that things like member 360s or provider 360s,
Right.
and big debate we had internally, and I kept saying it's not, it's an event, it's a trigger of assimilation of a lot of different information that needs to be served up through
Mhm.
the right means to the right stakeholders at the right time in a meaningful way to make an influential decision.
Mhm.
And that to me is data. That is
Right.
to the future of data. It's in, and
So.
it's exciting because on top of that is where all this intelligence exists. That's when
And
you can apply intelligence.
it's interesting. And two things you remind me of, Bill. One is I forgot to mention to anybody in the audience, if you have questions, please put them in the chat, and Bill and I will try to address them as we go along. And the second thing, in a minute, Bill, I'd love to just give our audience also an idea of your current roles and responsibilities as it relates to what we're talking about here, because they need to understand that your depth of the current responsibility driving this. So if I hear you remind me, Bill, of when I was teaching decision analytics at Harvard Business School, we had a bunch of old chestnuts that everybody uses. It's a hypothesis driven,
Yeah.
approach. And then we actually used to do an exercise about the expected value of perfect information. So the
Yeah.
expected value of perfect information before you go get the information, how's it going to move your, and so you're saying, hey, look, if I hear you, we shouldn't be thinking just from a supply side. We should be thinking from a demand side. What decision am I going to make on this? Can I assemble it when it's important in a coherent and high quality way? If
Yeah.
I heard you. And
That
so,
is
and
correct.
that, yeah, because the supply side could be infinite. You could
Yeah.
make, okay, great. You could have everything and you might use it, but that's
Yeah.
at some point diminishing returns.
Absolutely.
Yeah. So just to give our audience an idea of how, in your responsibilities, what they are and how this reflects in that.
Sure. Yeah, I think that's very important. My current responsibility is, of course, I am the CIO at Blue Cross Blue Shield of Michigan, but I think it's important to understand Michigan in its model because
Yes.
that goes is we are the third largest Blues plan, serve over 5.7 million. We're called a single state. However, we have 10 now subsidiaries. We provide services in all 50 states, healthcare related services. We also do property and casualty work in one of our subsidiaries, but all of it's directly tied to healthcare. We have by far the most out of what for the blue system, what we call out-of-state membership, because the nature of our customers in Michigan,
Sure.
large autos, et cetera. And we'll probably be a $35 billion company this year. We've grown obviously through the traditional history of what a blue system was about, which was at one point the system of last resort for care when someone couldn't get care. We continue to support. We're in all lines of business: Medicare, Medicaid, and all the different commercial lines of business. But most importantly, we're very active in the services around it, including both in the provider. We're doing a lot of work in the provider space. We philosophically, and other payers have made different choices, we've chosen not to own the provider, but yet the assistant to help organize it, but also supplement with alternative care models. You mentioned some earlier. Certainly with COVID, the telemedicine has grown even more, that in what's going to be more with devices and at-home treatment, all needs to fit as part of this ecosystem. So I'm the enterprise CIO. We have the 9 companies. Some do have their own CIOs that report up to me, but I also head up the company enterprise analytics. It was a decision that they felt. So it was a commitment after years of challenge that the company was struggling, trying to get their arms around how do we solve analytics at an enterprise level. We have that. It's gone unbelievably well. In everything we do is cloud-based at this point. I know we have the largest cloud-based infrastructure doing data and analytics now of a payer out there. It supports all our strategic provider engagement models and value-based and other care delivery models. It supports all our new advocacy programs for our digital care models. It's grown beyond my wildest dreams. We can't move fast enough, and yet we're moving 10 times faster than the company ever did. But it's because we came at it in a much different way. We always were a partial owner of an entity called NASCO. It was a formation 35 years ago by a handful of blues. Michigan was one of them, to be an entity to provide a common platform for the blue system who participated, because there's challenges of that. NASCO's grown. It's a $300 million company, has 20 plus million members. We're now the sole owner of that company. It reports up to me as well. A big part of us is that ecosystem. We want to continue to help facilitate and drive ecosystem to provide a much better outcome across all state lines in supporting of our blues customers and our blue members.
Yeah, that's a huge. How many different blues does NASCO serve roughly?
Right now, there are 9 major customers. But it represents probably about 30% of the entire blues membership.
Wow, huge. And so, Bill, back to our first question about the kinds of data and so forth, and then you're saying about how things are at the enterprise level at a $35 billion organization. It's going swimmingly well. How did you make the case for that? Because a lot of people don't like to give up their data and get at the enterprise level. And I'm reminded of the saying, old age and treachery beats youth and exuberance every time. There's a lot of experienced operators in the blues that know how to hold on to their data if they want to. How did you make the case for that, and what were the big leadership issues as you went after this data?
Yeah, John, you probably hit the point that I would argue is the most important thing, is how do you drive change? And some of that is culturally. I always tell people, the first thing I came out and the board asked about strategy for the vision, I said, I could paint that to you and come back next week and show you how this should work. The hard part is, how do we get there? And we have to recognize it's a journey, and you don't just flip a switch, and it's not just go hire a bunch of new people. We have real customers who expect service every day. We have expectations we made to them, commitments we made to them. There's things that we implemented 25 years ago that are still important to our customers that people don't even know how work anymore. And you have to think through how you go about it. But here's getting back to your point. To me, first thing I did, and it gets a little, we could talk agile, we could talk those are all part of it, all those method techniques. But my first thing is, The pillar of the strategy to this was, and I say it all the time, we don't do it to the business, we do it with the business. Okay.
Right.
At the same token, we got to find champions. We got to find a handful of people that are in the right roles to influence, and then we have to do it. And do it doesn't mean, because the first time I talked about all this, my technology teams came back and they said, here's what it'll take. For 150 million, we can start building out an architecture. I said, nope. How about $50,000 and let's get a proof of concept going with
Right.
the business? And they looked at me like something was wrong. I said, no, we're not. I'm not asking for that kind of money. We may end up spending 150 million,
Right.
but we're going to start doing this with the business and showing we have a vision of how this should all work. But
Mm-hmm.
what do we need to have in place today to successfully deliver on that use case and show
Mm-hmm.
progress? It was one win after another, just a little
Mm-hmm.
bit. And people said, that's never happened before. You actually
Right.
delivered that in 3 months, and I got it. And then another one came along, and then another one came along. And
Sure.
then all of a sudden, they saw the value of an enterprise leveraging it, because when they said, we need that information, I said, yeah, we just did it over here. I can make it accessible to you too. We just need to
Right.
shape it a little differently. And we built the architecture and infrastructure that doing it with a vision that we constantly refine. So planning to me is a totally different concept. I tell people I don't have my own, of course, I have to present an IT strategy, but I don't really have an IT strategy. I'm embedded in every business's strategy
Right.
and at the enterprise strategy. And I need to work and continue to evolve and refine that through a regular process. Because if I would have, when we started this journey, half the technologies I'm using to revamp what I'm in, people laugh, they say, well, it's security. No, how you do identity and access management in this new data world is
Mm-hmm.
a big challenge. Okay. It's
Absolutely.
not like plugging into my old back end. It has to work easily. How you get consent to allow information to flow.
Sure.
And so you need to have a vision, but you need to get people comfortable with not having everything figured out, but keep refining it. So
Sure.
pillar to that has been bite by
Right.
bite. And now I don't even have to, it's almost scary. And I tell people with that comes a big responsibility. If I go to the executive team and say, we need $2 million to go do X, they just say, go do it,
Right.
because they know it'll get done. And it's, or if there is issues, we're honest about what went wrong.
Sure.
It's part of building a culture where they trust, they believe, you're transparent, you don't come across like you have all the answers, you're not trying to paint them like we need to do this
Mhm.
agile and we're going to be a great company if we're agile. And
Right.
it's not in a, wait a minute, I believe in agile, but that is not going to make us a great company.
Right.
Yeah, it's an enabler. How does the tool in the toolkit be applied to best solve the problem? But also having some tough conversations. Like I just left with the business on one because they have all these ideas they want to do. It's like, guys, I don't understand what you're really trying to accomplish here.
Right.
I really hate working on something when I don't know what the outcome is. I
So
get theoretically, but
yeah.
we got to get better than theoretically to actually put that kind of money into something.
So it's really about being that business partner and help drive to business value and making sure the business is headed that way as well.
Yeah.
And to do it in an iterative manner, not, hey, give me 150 million bucks, I'll come back in 2 years with something you might use. Yeah, it's interesting, Bill. In the context of that, if we go back to the question we started with about what kinds of data and so forth, there's these big pools of data people talk about, right?
Yeah.
You have the EHR, then you've got all this clinical data, and now you have all this telemetry data. I'm hooked up to my continuous glucose monitor, and then you have all the quality data around the providers and all that other stuff. How do you think about what are the big hunks of data? And what are the ones that are really driving? And I'm going to get to the AI question in a bit, but
Yeah.
what are really driving value now? And just to give you one example, for example, I was talking to a very large provider the other day, and a couple of days ago down in beautiful Nashville, where there are lots
Yeah.
of providers. And Nashville's a great town, by the way, and growing like a weed. My God. Anyway, so he was basically saying, "Hey, look, there's going to be very little that we're going to integrate in this company is a series of providers that have been rolled up, and they're going to buy some acute care and so forth. And they're saying, look, we don't need data standardization. We don't want EHR standardization. It's not in the words of my grandmother, the run is not worth the slide. It's too much work to get it done." And he was coming off the fact, he said, look, it's rare that provision of care actually goes across geographies, right?
Yeah.
Somebody might move someplace, but then, okay, that's a one-time move. But they don't really need data standardization at the EHR level. Now, for other things, purchasing, care management, and so forth, they're going to drive those. So how do you think about what are those pools of data and where are they going to add value?
Oh, I think you're spot on. The actual data sources come from so many different places that you can't even imagine today. And it isn't all structured. The IT centric model of the world, and I can make fun of IT because I am IT and I'm part of the industry that created this. We always want standards. We always want to adopt. And sometimes even fire, and I'm a big supporter of what's occurred there because it's moving us in the right direction. But even that defines standards. There isn't. But it gives me a mechanism, a chassis that if I do this right, my goal is to quickly be able to get access to that information. Now, whether I need to bring it in to leverage it with other things, or whether I need to understand it to be able to apply to make decisions is important. So, for example, one of the big things we've done, which one of the pleasures I have working for this company and in what we do is, we have a very strong social mission and to improve the health in our community. And we dedicate a lot of time and money to that. We're a business too. We have to compete against the nationals and the for-profit, but care is still local. And so when we went to I'm going to use the word care management redesign. It's not the traditional care management redesign, but how care coordination, how we do it. We made that decision that it had to be geographically based, that we had to not have a solution that like a standard. The challenge to me is like, I had to have solutions that work at a scale and I can't have 15 different solutions, but can we find ways so that if in parts of our rural part of our state where you have a lack of good mental health providers or any mental health provider in some cases, or you don't have the specialties to deal with some of the issues, or you don't have good support systems, what's the mechanism that I can bring to that population that gives them answers or choices or options how to deal with that problem? Or the primary care who's trying to help triage all this, how can I help them make decisions knowing what's there? In other cases, if the right answer, and we do this a lot, there's support groups out there for family support through mechanisms for substance and alcohol abuse issues. There's ways you can tap into those entities. And I'm not saying to the degree like we tap into our hospitals and EMRs, that you can bring that information to bear and you can coordinate it to saying, this is the family of things that are important for this individual to be engaged in. And we, doctor, can help you navigate that. And if we have to reach out to get the schedule for you for mental health, we'll do that. Now, in the case of telemedicine, that's now more acceptable and it's grown. There's more going that way. There are other ways we can introduce that into the setting. The point is, that's a very different model in where there's a population of 3,000 people and they're 150 miles from the major first a trauma center to downtown Detroit. It's a very different solution. Yet I have to have a solution that's, well, it only works here. It has to work in all those places.
It's really interesting, Bill. What I hear you saying, tell me if I got this right, that there's really a movement from a notion of standardization from the technology out to really service provision in almost a playbook sense or a set of protocol sense that is more like service availability, some of which might be human services, some of which might be technology enabled services, some of which are straight technology services that are more configured and on an on-demand basis to help them solve their problem. But it's not about driving. So it's about driving frameworks and service models and similarities, not about standardization at the data level.
That's correct. And to me, you get into the AI question, which I know you're going to go deeper on, but all that stuff sits on top of this. AI is in everything, and it helps inform and guide this because it can bring other factors into it that said, I've seen this before, or these are the right things that work. And it doesn't depend on having a human have to remember every aspect of the local market, the doctors in the market, what's available. It can help guide that whole pattern if you build it on top of this ecosystem, as I call it.
In the context of this, Bill Korsland asked us a question that how do we see the patient's role in managing their own health evolving as these changes come in health informatics and AI?
This is Bill speaking from a philosophical, but I also know our company's making has some strategies going this. What you and I, okay, if you really go through healthcare, I always think, I'm not a historian, I don't claim to be, but I do believe history does teach you an awful lot. Healthcare used to be a place of last resort. You took care of yourself unless you got really sick, and then you had catastrophic care. That obviously changed.
My grandma lived to be 105, and I used to ask her, I say, Nana, what did this person die of? It was always shortness of breath. Well, he died of shortness of breath. Of course.
But that's what healthcare was. And then it changed, and employers used it as a competitive advantage to attract or retain. And it's evolved. But here's the interesting part. And I gave examples of how the whole person health view is important, not just the right doctor, the right hospital, the right care plan after they're sick. It's way before that. And if you know our business, and most people who study the healthcare guys, maybe 10, 15% of our membership, 5.7 million, only 10, 50, will ever file a claim in a year. Okay. Now, some of those are pretty darn big claims, but the rest of them, there are things we do for the rest of them. There are things we offer, but that's the people you got to figure out how to engage. But there's a change going on. And I don't even want to say younger versus older. What is important to a person? I would argue today people treat their dietitians, their massage therapists, their health clubs, all these alternative medicines that people do. That's how they think about health. Okay. They don't think about health as going to a hospital. They think about it as a place to go only if I really have a problem. And so getting back to the question, everyone's defining it differently, and we're going through that change. And I do think people are going to Google answers. This is happening to me. What are my options? That's just a fact. And they're going to get direction. And we need to figure out how to play that. Now, at the same token, we've tried, in our healthcare system, and there's enough books, and John, you've done research, I know. Is it a carrot or is it a stick to get people to do things? And we certainly do things to try to do incentives. And ultimately, it's up to a person to decide if it's important enough for them to do the right things. But if they're educated, they have access to those things. We overcome the fact that in certain parts of our country, you could talk about a great diet, but if it costs 10 times more to get healthy food than it does, what's going to happen when people are trying to meet? If there's ways as a society and as a system and us as a health plan, we can help to solve for that. We're giving information to people what's important to them. They ultimately have to make the choice. And there's nothing we can do about that directly other than trying to incent them more and more. but I don't think the gimmicks work. I think it has to be something that's sticky. It's something
Hmm.
that really is important to them. But we all have events. And when you have an event, all of a sudden your mindset on things shift. And
Yes.
then maybe you get them. And then but you can't just send flyers home. You can't just send a bunch of cards to them. It
Sure.
has to be something that fits into the fabric of their life. And it has to go beyond, I am now sick. What's the best doctor to go find to help me solve that?
Sure. Yeah. And then you look at, I'm sure you've seen the stuff by network theorists like Christakis out of Harvard, and looking at the Framingham Heart Study data showing that, yes, it's individual choice. And at the same time, it's the thing my grandmother used to tell me: show me who your friends are and I'll tell you who you are. If your community and interaction is with unhealthy people, you're more likely to be unhealthy. Now, does that absolve you from personal accountability? I don't think so, but it certainly shapes the likely outcome.
There's such a, I'm not going to get into politics, but you could have these very interesting dialogues of, y- there's a big economic, let's even talk, had a unbelievable discussion on a different concept with some of these drugs out there, some of these advanced the research what's going on there and where they're coming from. They used to come, lots come from the academic side, but
Sure.
it may be only able to help 100 people or 1,000 people because those are the only people that have these diseases. In each, that's millions of dollars just for those drugs for those
Sure.
people. But how we finance healthcare in the future, I think, is going to become a very interesting dialogue. And there
Oh, yeah.
is a different way to do this than how we do it today that can be solved. And I'm excited because I think people are starting to talk the right way
Yes.
about that.
No, it's one of my adult children has MS, and he takes
Mm.
Ocrevus, and it's $135,000 a dose. He gets it twice a year. It's just it's a lot of dough. And so back to Bill's question, then I think what we're coming to, Bill, is that both Bills, you Bill and Bill Corsland, is that AI is going to be a component. Sounds like both on the search side for the individual taking
Yeah.
accountability and what gets served up to them, and then also as they get into the care model, the insights, the capabilities, and so forth of those care models is going to be enhanced by what we can learn from AI. Is that a fair?
No question. I call it AI everywhere. It's
Mm-hmm.
embedded in everything. And it's not just about, here's now one thing inherent in that question that I really don't want to lose sight of to the audience because we all need to be sensitive. The ethics of all this stuff in this is serious stuff. Data by definition has biases in it.
Of
Okay.
course.
Even in it unintentional, but biases. You pull a poll saying, yeah, in this part of the country they're sicker. Of course, you didn't, and so then you start to make decisions on that. Why are they sicker? They're sicker because they're the air quality, the access to the right care provisions, the preventive care options. And as we think about AI and we think about all this, there is an important part of this. We have to understand and have a discipline. And within my enterprise analytics, we have an ethics part of this, which says what's bias inherently in these things
Sure.
that we need to deal with and ensure that we're not making the wrong decisions. Because part of the problems with AI is it will do it and
Oh,
it
yeah.
may be the right answer, but it's inherently the wrong thing because of what it's been fed. And but where I would say the benefits of all this, sir, I can think of a gazillion administrative savings opportunities, but it's really not that. It's how do I provide more information more effectively, timely, that's been thought through to help guide the individual, whether that's directly through a digital thing, the member in our case, or the patient, or the person who's supporting them, a
Right.
caregiver at home, or a doctor, or our nurses. So they're helping make much better decisions than ever
Yes.
before. And also learning, and you learn from things and building that learning back so that we're even better next time.
Yeah. As I think Bill on and off studied the financial, ethical, and organizational implications of AI. My thesis was on it in 1986, so it's been at it for a while. And yeah, the thing I've consistently seen is just what you said. There's bimodal. On the one hand, you can pick up the trash with it. So it's like the Roomba of, if you, I keep trying to buy a Roomba. My wife doesn't want it. My pugs go nuts, but I want a Roomba. So anyway, but it's like the automatic robot that picks up on the one hand, and that's got all kinds of economic implications on compliance and administration and billing and blah 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 blah. And there's lots of money there. And then on the other side, it's really the telescope for the mind, or the scuba gear for the mind, where you can go do new things or take groups up another whole level of understanding because of its ability to expand collective cognition and to decrease those limits and to have insights like the Google stuff on breast cancer diagnosis for radiologic images. I forget the exact numbers, but it was like they detect it like 5 to 7 days earlier. It's 30% more accurate. You have fewer false positives. Huge implications economically, but on a human basis, to have that increased accuracy on something so vital as whether or not you have breast cancer, it's just amazing, right?
It is. No question.
Yeah,
there's so many applications to it, but I also think it's everywhere. It's just it's going to be embedded in everything we do. And then what is that interaction between how you govern that, and I don't like the word govern, but I'm going to use it because it is, along with how it applies to your workforce who's leveraging and using it. That's a big change. Big change.
Yeah, it's interesting. You and I both know Alan Kay pretty well, the guy who invented object-oriented programming. And the thing that Alan said a long time ago and kicked around with him is, I think the right image for this is not mechanical, but biological. So it's not a machine that's alive. And if you think about where things are going with AI, I think it's very much like your body. Like, there's a tremendous amount of intelligence embedded in every cell of my body. And then there's expression systems to take that intelligence and to only pass along what's necessary from location to location or locality to locality. And I think we're going to see that. And you start to see it now with a bunch of the lights that have embedded AI in them to do pattern recognition. But you're not going to ship all that data to some AI somewhere. It's going to be a little neural net in the light bulb that's going to then just pass along, just like your cells do, proteins or other, And so I think that just as you said, I just wanted to dive in a little, because when you say AI ever, it's really profound. And I think, to my mind, the right analogy is biologic, which is you have living information that passes along certain things. And the amount of intelligence that sits different places is going to be very different.
You said it perfectly. And that's what I mean exactly with AI, where the data that's most valuable to me in what we do to support our business will be the data that'll probably never reside in my environment, but I will tap into it to take advantage of it, to leverage it to help make a better decision.
And you'll get those signals, and maybe sometimes you'll trace those signals all the way down to the source, and you'll unpack it and so forth. And other times you'll just take the signal that gets passed along.
There's I saw there's a question, and I know we'll get more in depth on this with value-based, but here's my funny thing. And I said this when I was in 2008 or 9, when obviously as healthcare, the out-of-pocket costs started to go up. That's how people controlled costs. And everyone wanted these tools for transparency, and so people could make, and then CDH, consumer-directed health plan, blah, 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 all that kept happening. I kept saying, and they said, how do we get people? And all this work that people did to steer, they called it, that's a bad word now, by the way, steerage, but it used to be a word. And
sounds very bovine.
Yeah, exactly. But now it's navigate or whatever. But the point was, I laughed because I was in IT and I wasn't at Michigan at the time. I'm like, okay, you understand our claim counts haven't gone up, but our eligibility and benefit requests are like 10x what they used to be, in growing straight, because every doctor, hospital out there, the first thing they're asking for is, are you covered for this? And to what extent? Because I need to collect money. And I said, so here we are, we take all this data, then we go out and teach our doctors there could have been a better effective way to treat this patient. And value-based care grew from that. But yet this information's flowing. And I said, why can't we? Because the care wasn't delivered yet. They're asking a question. They're asking a question couldn't I tap right then and there saying, you're looking for that kind of service? I know the patient, the member you're doing it for.
Hmm.
Let me give you some guidance right now here on this person and some other factors that's in your best interest. And yet we still treat that as an administrative transaction,
Hmm.
not as an information transaction.
Isn't it
And
interesting? Yeah.
and there's billions of those flowing every day before care is delivered, people trying to make decisions
Right.
and whether they're covered or not. And that already tells you that a person's in there engaged. Yet we wait until after they need an authorization or referral. We're already too far down. We already should be guiding it right
Right.
then and there. We should have been guiding it before any decision was made.
Wow, that is really a brilliant insight. That when you say, okay, if you think of care before all these options and so forth as being relatively stable, I know medicine's always moving and dynamic and so forth, but relatively stable in terms of who makes what decisions at what time points. As you have the explication of options, the digitization of possibilities, that then opens it takes stuff that, just as you said, used to be administrative, and now actually, if I had it at the right time, it's clinical now. And so I'm one of the themes we talk about a lot in this Growth Innovator series is computability, the ability to compute reality.
Yeah.
And I know this sounds abstract, and I geek out on it for just a sec. If you think of any transaction, I think of when you can compute it, you basically open it up along the time dimension so you can predict better and you can see things happening sooner. So in a certain sense, you are expanding the time dimension on any event. And
Yeah.
then I think of it as top and bottom. You can think about the thing in aggregate, or you can go down into its component parts. So in a weird way, every transaction becomes expanded in space and time,
Yes.
as I can compute it more. And I never thought of it till you just said it, as those had annealed in the past into patterns, then those went to organizational roles, administrative, clinical. And what the computability language, I'd say, as we compute more and more of this stuff, you're reopening the decision space in a way that those roles now have to get reassessed. We're to create, and
My biggest challenge, not challenge, my biggest thing, and people look at me like, why are you asking this or why are you saying it? I said, I said, guys, the traditional functions and how we
right,
dissected our organization, we have to start rethinking that because we're
right,
not going to drive this change because they're optimizing this.
right,
That has as much clinical and other member insights
right,
as the stuff you're gaining from the EMR,
yeah.
and yet you're waiting for me to bring it together, but that's too late.
It really, and we've got Michael Newman here who's asked about value-based care. Why is it a slow roll from fee for service to value-based services? And then Kurt also, Hildebrandt has asked, okay, what about metadata in digital health services and so forth? And to me, the way you're thinking about it has at least something to say about both of those, right? One is that the value-based care thing, in terms of what functions come where, we didn't address the risk, who absorbs the risk
Yeah.
piece, which is really interesting. And then on the metadata stuff, yeah, if you're expanding, it's not just metadata, it's metadata when, like in the decision process and the payment process. It really leads to a re-examination of roles and really what's professional practice in the context of that. Yeah, it's interesting on the value-based care thing. The thing I always heard, Bill, and I don't know if you agree with this, the kind of simple answer to that was it's where the risk sits. Like the National Healthcare Service in the UK, like it or don't like it, it pays for them to do preventative care. For some of the
Right.
payers, less so for you guys because you have not so much a profit mission. I've talked to a lot of payers, and once the cameras are off and nobody's talking, it's like, hey, we don't want to do preventative care because there's two things. First of all, we don't get the benefit of it on the backside. Second is it decreases our primary demand.
Yeah.
It's not like they want sick people, but they're not going to put a lot of money into preventative care if people can move and they don't get the value.
I think yes, and I'll give you for someone, and this is you brought up you did mention I worked at Blue Cross and Mass, and we were one of the first to roll out a very expansive value-based. It wasn't called that as alternative quality contract, but it's value-based care, and that got a lot of time in Congress and other places, and we
Yep.
did a lot of work there. And by the way, there's no question paying attention that getting the data, and some talks about metadata, and are we actually looking at the right data, and is it accurate in quality, and how do we make decisions?
Sure.
There's benefit to that. But the problem with a lot of this stuff, it gets into this panacea thing where everyone then's going to do it. I would argue what's happening, and we've shifted dramatically, a strong believer in risk. We
Mhm.
want more and more shared risk. to the right outcome for the patient.
Mm-hmm.
But it's got to be segmented differently. You can't do it at a major system level. Some
Mm-hmm.
of it may be based on certain chronic diseases.
Right.
Some of it may be based on certain population targets that you're doing it.
Sure.
So, what's starting to happen, which I actually think is the right shift, the umbrella of a concept of value-based care and all the things that go on are there, but
Yes.
we're now creating for a Medicare population who
Yes.
has these unique needs.
Right.
We're building a relationship with this provider group to
Right.
produce value-based care. And
Yes.
so trust me, as someone who's got to administer this technologically, this is
Right.
complicated stuff, but
Sure.
it solves the problem because otherwise it's a peanut butter thing, right?
Yeah.
in
Well,
in
yeah.
in
Mhm.
in one size doesn't fit all. So I actually think it's starting to morph into a much better place. I think we also there's some if you research how Medicare is starting to do their incentive programs and starting to
Sure.
shift, there's a lot of learnings there that you can see it coming. You
Yeah.
can see how that's going to shift in the commercial side and things as well. So
Mhm.
I don't think it's necessarily not coming as fast. I think people realize just doing it does in itself.
Yeah.
You have to be very smart about the population, the targets, the
Right.
outcomes, and that's all heavy lifting on analytics and data in decisioning and building the right structures,
Right.
contractual and legal structures to do that.
Yeah, and as you say, the care model I'm reminded of in specialty insurance, Hartford Steam Boiler Company, which started I think in 1883 or something, and they're a specialty insurance carrier, but they have about 3,000 employees, very profitable. They were brought together because every once in a while a boiler in New York City would blow up in an apartment block and kill lots of people and stuff, and so a bunch of the landowners and landlords got together and said, why don't we engineer these things and not blow them up so much? But the interesting thing about their model is they've got about 3,000 employees. 2,000 of them are engineers doing improvement for heating cooling systems so that they are more efficient and don't blow up and things like that.
Yeah.
And so you have that integrated risk cover care provision. And I hear you saying, look, in some areas that's the case. And then if you step back and look at your cost model, somebody like my son, who's $260,000 for 2 injections, it's such a skewed, specific.
Yeah.
When you look at what's the thing about 95% of your healthcare costs is spent in the last 18 months of your life
Yeah.
or something of that
Yeah,
order.
exactly.
So you
Yeah.
look at this is not automobile insurance where give me your age or give me your model and give me your sex and I can know it. This is hugely skewed, and the interaction between the care model and the cost is so deep. You would expect differentiated models that then get funded, and whether that sits under a big umbrella like you folks with a zillion businesses underneath like Warren Buffett's Berkshire Hathaway, or whether it looks more franchised, who the heck knows?
Who knows? And I think we're all in that. I think the point is we're learning, it's evolving.
Yeah.
I think it's evolving in a positive way,
Mm-hmm.
but boy, it's going to shake up things over time. No
Yeah,
question.
and not to get political and so forth, but the other thing that does bug me a little bit is that I do think that the U.S. and there's some pharmaceutical companies that have bad behavior. Okay.
Yeah.
But I do think it's mainly true that the U.S. does do the R&D budget for the world on pharma, and the American healthcare consumer pays for that, and then the stuff that works gets transferred globally at a comparatively low cost. I don't know if you would
I
agree with
agree.
that.
I think absolutely. And in the recent research I just mentioned earlier of if you go back 20 years and how much innovation came out of the pharma for these versus now what's coming out of the academic institutions, even and other thirds, spot on. But we're funding that. I
Right.
mean, all these institutions that we've created, we fund through our tax dollars, everything. And listen, I think it's great what we do, but the world benefits from it.
Yeah.
No
So
question.
when you do
No question.
the comparative cost, it's okay. A slice of that difference is the R&D for the world that we pay for.
Yeah.
Anyway.
And you could argue that's true in almost every part of healthcare. We've had this discussion. I don't smoke. I exercise. I'm healthy. My neighbor doesn't take care of themselves. He's at the hospital every week. Yeah, in some ways I'm subsidizing that. That's part of our world. But your point about the world is something our country is going to have to reconcile with. No question, because these advancements we are, but we don't always reap the benefits. And I think somehow those benefits have to come back into us. And I think it goes back to the financing, but also how we allow these legal structures to operate
Yeah.
to make sure the US benefits from all the R&D that we committed to.
Right. Yeah. Hey, I know we've only got about 4 minutes left here. Bill, very briefly, I would like you to just address for those in the audience who are not in the healthcare field, but are executives at other places, what are the one or two things you think they need to keep an eye on and think about when they think about healthcare over the next 5 to 10 years?
I think first and foremost, the shift that you'll see if you think about where you go and where you select healthcare, there's going to be so many new alternative models or different approaches that having the information or the support to help make the right decisions if you're an employer for your customer base is critical, very more so than ever. It's too easy to fall in the trap of what the right price is. Secondly is keep your eyes on the reality of the aging population. The growth in Medicaid is a byproduct. A lot of it came as a byproduct through COVID. The growth in Medicare is going to cause some really interesting dynamics to all of us financially and through other means. And there's some great stuff going there. And we're in all those programs. You need to understand that dynamic and how that plays out. And I do think as an individual in a company, really wrestling with is what is the responsibility of the employee in this, not just out of their pocket. What position do you want to take? Now, for all of us who are fighting to attract, retain talent right now, we're doing everything we can, but it is something we all have to face. What is the responsibility of the individual? And is there something I can do? I can't tell you the number of things we're doing uniquely with some of our big customers now that I thought we'd never do on site to help them in creating these unique models so their employees can be as productive as possible, but also get immediate access to things. Those are very relevant things because this healthcare dollar and the reality of it is going to impact all of us. That would be my feedback.
That's really fantastic. So really understand, don't just buy on price, really understand quality and function and so forth.
Yeah.
Keep an eye on Medicare, Medicaid, because as the pig goes through that snake, we're going to get costs, but we're also going to get innovations and interesting things.
Yeah.
And then the thing about the accountability, responsibility of the individual employee in the context of a competitive labor market. Those seem to be very useful, practical kinds of things as certainly just as I sit here as an executive at Manifold, I think about our folks, we're wrestling with those. Awesome. Thank you, Bill. I can't thank you enough, man. I wish we had 5 more hours to do this.
Well, and great questions and always a pleasure. Thank you, John.
Great to be with you, Bill. Thank you.
All right. Okay. Take care.
Bye-bye. So in terms of, just want to do a rest of the story here, just wanted to remind all of us that the Ed Jenner started in on a smallpox vaccine in the 1800s, but back in the 1700s, there was an African slave by the name of one Cyrus who was owned by Cotton Mather, who was a pretty influential academic and a preacher in the Boston area, New England area. And one Cyrus actually brought over how the African tribes had started an inoculation by taking small amounts of pus and putting it into folks so that they would not get as sick. And so the beginnings of the whole notion of smallpox really does have its history much deeper and broader. And Cotton Mather also was, the Mather family was pretty big at Harvard University. Harvard's just put out a whole study of the role of slavery and Harvard's role in it and benefits it got from it, economically and otherwise. So I just wanted to remind us, long before modern smallpox vaccines were around, we were learning from some people who came here not of their own volition, but were willing to share their wisdom to keep us all healthy. If anything here is of interest to you, please feel free to reuse this content. Happy to have a conversation about it. And we believe in open source and share and share alike. So the Creative Commons license is what we use here. And just if you use any of these materials, feel free to use them. Just tell folks where you got them. And that's what's the kind of Creative Commons license we use. We've also started since our last one, what we call the Healthcare Pulse, which is a new community for leaders in healthcare. And if you want to join this community, simply you can scan this and join and connect with other senior leaders. We're just kicking this off over the past month or so. We're going to be putting lots of content in there, everything from economic content to clinical trends and technology and so forth. And would love to have you be part of that conversation. And we're really excited about this. We think it's going to be a great community to have these conversations about the things that matter to healthcare. And as part of this, our next month's speaker is going to be Mary Vandekamp. She's SVP and Chief Clinical Officer to Kindred Hospital Rehab Services, and they're doing all kinds of innovation in rehab. And she's served in them for almost 30 years now, both on clinical and operational side. So she's going to bring a new perspective about what's really happening on the ground and where they're going with clinical services as an innovator in that domain. I hope you can join us again next month. And as I say, feel free to use these things. I want to again thank Bill for a wonderful set of insights, and to hope to see you again next month in our Growth Innovator series. And thank you.